I think this year there were a couple of updates about trials. I don't think there was anything like new that we were not expecting. So I think, I think we have grown accustomed for the last couple of years of seeing at ASCO like big change, practice change in trials. I don't think that was the case this year for GYN, for GYN cancers. There was update from DOE that it's a trial looking at PARP inhibitors in combination for patients with endometrial cancer, in combination with immunotherapy. But other than that, I don't think there was any remarkable thing that I would highlight from ASCO from this year.
Okay, thank you. So I know that speaking of highlights and some, great exemplary work, I know that you are doing some great work in understanding the genetic drivers of ovarian cancer, right? And also to promote genetic testing within our population and also the family members. So tell us about your Ignite-X study and what should our overcomers know about it, and what can they share with their family members when it comes to the study? So that would be extremely helpful.
Yeah. So as probably most of the participants in the call are aware, many of the ovarian cancers that we see are hereditary. So that means that patients may have a mutation in mostly BRCA, but also some patients might have mutations in Lynch syndrome, might have Lynch syndrome. And probably like around 20%, 20 to 25% of the ovarian cancers that we see have some hereditary component. So I would say probably the most important thing that I'm going to say in the conversation today is that if you have been diagnosed with ovarian cancer or have a family member that has been recently diagnosed with ovarian cancer, it's very, very important that they undergo genetic testing. And genetic testing can be nowadays fairly straightforward. It's covered by insurance. And you can either your GYN oncologist, your oncologist, or a genetic counselor can help you or your family member undergo that genetic testing. So that is the most important thing, because if you have a mutation in BRCA right now, and especially in the front line, in the initial management, we have very effective therapies called PARP inhibitors that really have changed the landscape in ovarian cancer to the point that, and I'm just talking right now in the front line, that we believe that for those patients that have a BRCA mutation, if they receive a PARP inhibitor, we are curing those patients more so than what the normal standard of care with chemotherapy we were doing a couple of years ago. So that is the most important thing in the conversation today, that if you have been diagnosed with ovarian cancer or have a family member undergoing genetic testing is very, very important. So that's the first thing. The second thing is that if you've been diagnosed with BRCA, and it can be BRCA 1 or 2, and germline, that means that all the cells in your body have that mutation. So that means like you have a germline mutation. So if you have the germline BRCA mutation, that means that 50% of your first and second degree relatives have a risk of have the risk of having the same mutation. So 50%. So the reason why that is important is, let's say that you're diagnosed with ovarian cancer, you have a BRCA mutation, your daughter or your son or your sister has a 50% chance of having that mutation. And if they have that mutation, there are different strategies that we can offer patients to try to decrease the risk of having ovarian cancer or breast cancer or other cancers that are associated with BRCA. So let's say that a patient is diagnosed with BRCA, patient with ovarian cancer, they undergo the testing that we recommend, their family member undergoes the testing, and they're identified of kind of the same mutation, a BRCA mutation, then we can offer them removal of the ovaries and the fallopian tubes by surgery if they have completed child, if they don't want to have any more kids and they're after 35 years old. And if you're younger than that, we can do ultrasounds and blood tests to try to identify the cancer at an early stage, we can offer them early mammographies or breast MRIs as indicated. So it's very, very important for those family members first to undergo the testing, and then if they are positive, then subsequently to do the proper screening methods. So what we're trying to do with the Ignite TX, it's very simple, but it's a very simple strategy, but it's a very complex environment in which we are navigating for the testing. So what we know from different studies is that, many times patients with BRCA mutations communicate with their family members. So we know that 80% of the times, the patient with a BRCA mutation will tell their family members, okay, I have this mutation, you have to undergo the testing. The problem is that the family members only perform the testing like 20–50% of the times. And if you are from an underserved area, medical underserved area, the chance that you're getting testing is less than 10%. So we are not doing a very good job in communicating with family members so they can get the testing. So the whole goal of Ignite TX is a simple strategy, simple intervention to try to help the proband, the patient with the mutation, and the family members in communication so they can achieve the genetic testing.
Thank you so much. So there is a question actually that popped up on the chat right now, which is relevant to what you just said. So so the question is, if BRCA negative, then do family members still need to get tested?
So it's a very good question. So if the genetic testing is negative, right now the family members do not, they don't need to do the testing. It might be that in the future, as we study more, we might find new mutations, but as of now, that would not be indicated.
Okay, thank you. So we have several questions that were submitted for you. So I'm going to just read through them, and I will stop intermittently to ask our friends online if they have questions that they would like to ask you directly. So with that, the first question is, what are your thoughts about continuing PARP inhibitors as a first-line maintenance beyond 2 years?
So it's a very good question. So just as a reference, so right now, the indications for patients with BRCA mutations are for olaparib for 2 years and niraparib for 3 years. And why 2 years and 3 years? That's just the way the clinical trials were designed. For olaparib, I would not recommend going beyond 2 years. 2 reasons why is because we don't know if there's any benefit past 2 years. That's the reality. The second part is that we know that there are some side effects associated with PARP inhibitors. Some of them can be pretty fatal, and that's blood malignancies like leukemias and so forth. So it's rare. It's like happens less than 1% in the frontline setting, but we're still learning a lot about, these PARP inhibitors. So it's important to keep in mind that it's a relative new therapy. So I would not recommend going past 2 years. It's something that I have a lot of patients that ask me, and it's not easy. It's not a straightforward answer just because we don't know. And it may be that they might get some extra benefit, but as of now, what I recommend my patients is not to do it after 2 years for olaparib or 3 years for niraparib. Keep in mind that and I'm just talking about the recurrent setting, so patients that have had a recurrence and they were starting on PARP inhibitors, there's some data that in some populations, PARP inhibitors might be more harmful than actually helping. So we were very liberal of using PARP inhibitors in the recurrent setting, and now I think we're much more restrictive. And I would say nowadays, I think it's very clear that most patients that are going to receive a PARP inhibitor are going to receive it in the front line. But I think we have to be just a little cautious about, what has been published. And I think for olaparib, for olaparib 2 years and niraparib 3 years.
Thank you. So there's a follow-up to that. It's a different question, different person asking, but it is on maintenance therapy, on PARP inhibitors. So she's asking, what new maintenance therapies are in the pipeline for women who have finished 2 to 3 years of PARP, first-line therapy without a recurrence? And so according, the, these women are still at risk of recurrence, but at this point, there is no treatment, maintenance treatment available. So what is the plan?
So you're absolutely right that right now there's no approved maintenance therapy for those patients that have completed a PARP inhibitor and that have been disease-free. I don't think there's anything right now on the pipeline in which we are looking at, how to extend that period. Like when you look at the most recent data for those patients that have ERCA, received PARP inhibitor for 2 years, many of those patients are being cured. I mean, at least disease-free for more than 7 years. So I think, it's hard to stop the therapy, but we don't have any information about anything long-term. In the future, there might be other different therapies. There's a lot of things on the pipeline in platinum-resistant disease and platinum-sensitive disease, but for the frontline, we don't have anything for maintenance right now beyond, bevacizumab and PARP inhibitors and perhaps immunotherapy. And I said perhaps because I think the data is still, unclear whether there's going to be any use of immunotherapy in the frontline.
So Dr. Rauh-Hain, so for these patients who have been on this, like you said, I mean, after 2 to 3 years, there's really not a clear path. What is the suggested protocol for these patients? Just wait and watch?
Yeah, I mean, I'll say what I tell all my patients, that I think the best thing is to try to, don't think about ovarian cancer. They've done remarkably well. I think if they receive a PARP inhibitor for 2 years, they've reached a milestone that many patients don't reach, like being disease-free for 2 years. And hopefully they're never going to have a recurrence. But, if they have a recurrence, then at that point, we're going to be able to deal with it. But yeah, in terms of therapies, there is not much that we can do. I tell all my patients to try to enjoy life as much as they can, to try to minimize stress, and, hopefully the cancer will never recur. But in terms of therapy, there's really nothing that we could offer.
Okay, thank you. So there's a question in the chat, which is also, we are on the same trail of PARP. So the question is that, so I'd like to ask once again if the feeling in the medical community is that a OC1A, I mean, Ronnie, if you're here, you can ask the doctor directly if I'm not reading it right for you. And Dr. Rauh-Hain, you can probably also see this in the chat. OC1A or 2A, no BRCA/HRD, should use PARP or olaparib as a frontline maintenance drug, or can they wait for a recurrence if they're not platinum resistant and use it then?
So this is kind of these are such a good questions. So this is a little gray area, right? Because all the trials included patients with stage 3 and stage 4 in the front line. So what I would tell you, if this is the case, someone with stage 2A, HRD positive, I would recommend olaparib in the front line for 2 years. That would be my recommendation. You might hear different opinions about it, but I think for someone with stage 2, there's a pretty significant risk of recurrence, and I think that's a patient that I wouldn't say that they have to take olaparib, but I would say that's something that I would definitely discuss with the patient and think about it.
Ronnie, go ahead if you have a question. Follow
Thank
up.
you so much, Mercy. Thank you so much, doctor. Actually, I'm 2A HRD positive, but what I didn't add was that, and what made it difficult, my doctor would not weigh in because there isn't, let's have the research. We're really hoping that it gets extended to see how 2s do, and that it isn't, the risk reward thing is reasonable for them. But if you have also pre-existing things, for example, 2 or 3 autoimmune diseases that you have to factor in, and perhaps something like chronic Lyme disease, or something. Also, one of the pills you take for heart medicine is contraindicated. So you're factoring these things in. Does it then become something where it is more difficult then to decide if a 2A who had a very successful, let's say, surgery and did very well in chemo, whether they should do it, especially if they start and they have pretty serious side effects from it?
Yeah, 100%.
Yeah, so you have to consider all that then, doctor, correct? I mean, more or less.
100%, yes. Like, I think if you're doing something that it's outside of the standard of care, I think you have to be very careful. And I agree with you. I would only offer it for someone who is pretty healthy, great performance status, really no other contraindication, and that understands the limitations of the data, understands the potential side effects, and with that in mind, decides to undergo the therapy. But yes, I mean, everything that if I were seeing a patient with all the medical comorbidities you're describing, I would certainly be much more hesitant to offer a PARP inhibitor for sure. Yeah, I agree.
And may I just ask one follow-up? Is it possible, if you don't become platinum resistant, to begin olaparib, after, if you had a recurrence after a second?
So for platinum resistant now, there's really no indication for PARP inhibitors.
No, I mean, I meant it the other way. If you are not
platinum
if you're
resistant, not PARP, yeah,
and you go through another round of chemo, would you be able to take the Lynparza as a second? Yes. Oh, thank you very much. That's great news. Thank you.
If you're platinum sensitive, so if you have your first recurrence, you're platinum sensitive, and you respond to the chemotherapy, then yes, and you're HRD positive, you would be a very good candidate to receive olaparib at that point.
Thank you. That's wonderful news. Thank you.
Thank you, Dr. Rauh-Hain. Thank you, Ronnie. So moving on to the next question. The next question is, what are your thoughts on vaginal estrogen for ovarian cancer patients, and is it risky to use? And does it also make a difference in the risk factor scale if a patient has low versus high-grade cancer, or has hormone positive or negative?
So, I start with high-grade serous ovarian cancers, and keep in mind that the definition between low-grade and high-grade, it's fairly recent, maybe in the last 15 years, that we have come to understand them as a very different disease, very, very different disease that now we are like managing very, very differently. So for high-grade ovarian cancers, and I'm going to keep repeating, there's really no data about the safety about using vaginal estrogen. There may be a couple of retrospective or very, very small studies suggesting that it's safe to use vaginal estrogen. So I think if I have a patient comes to me and they say, I would like to use vaginal estrogen, I would mention to them that the lack of data about the safety, and again, everything is about trade-offs. But I would not be opposed about using vaginal estrogen in that scenario. And also, the other thing about vaginal estrogen that it's important to keep in mind is that the amount of estrogen that really gets absorbed into the bloodstream, it's very, very, very small. So it's not that large. Really, most of the estrogen, it stays in the vaginal mucosa. So the amount of estrogen that really gets absorbed in the bloodstream is very, very small. I would say for low-grade ovarian cancers might be a little bit different, because as the person that asked the question, there might be patients that have low-grade ovarian cancer that are more hormone sensitive at some degree. They have higher rates of high expression of estrogen receptors and progesterone receptors, to the point that many times we treat low-grade ovarian cancers with hormonal therapies to try to mitigate, try to decrease the chance of the recurrence and so forth. Things like letrozole that you might have heard for breast cancer, and other therapies, hormonal therapies down the road if they have a recurrence. So again, in that setting, I would have a conversation with the patient. I would try other measures for vaginal dryness before I move to vaginal estrogen. If the patient has a lot of symptoms, then I would consider it, but understanding the potential risk of the little estrogen that maybe are absorbed might have on the cancer. So I don't think it's a complete contraindication, but it's just something to have a conversation and understand whether other therapies might be available.
Thank you, Dr. Rauh-Hain. So there is a follow-up question to that on the chat, and the question is that what would be then an alternative to vaginal estrogen? What would you recommend?
So there are things like Astroglide that it's just helps with the mucosa, like the dryness of the mucosa. I think some patients might get some benefit from those, and you can buy Astroglide from over the counter. So that's what I would try first. Other measures like things that you can buy over the counter for vaginal dryness, and then if that doesn't work, or it's the vaginal dryness is causing bleeding, then I think it would be okay to use vaginal estrogen. Again, understanding that there's no data at all about how safe it is in low-grade ovarian cancer, but I think the risk would be very, very, very low. But again, something to consider and to talk about.
Thank you. So we have another question here, which is, friends who are online, feel free to send in your questions via chat or ask Dr. Rauh-Hain directly as we go along. This is a very friendly, intimate, small forum, so you are welcome to ask the doctor. I was going to say director, but with your that too, I guess, live. So the next question is, when dealing with a small bowel obstruction and a PEG tube to drain the stomach and IV nutrition / TPN, I'm pretty sure you're understanding all of this. How often does the obstruction actually clear when on Mechanist alone, and the patient can resume eating, drinking as normal? And if you're here, please feel free to ask Dr. Rauh-Hain directly if I've missed anything. So did you get the question, Dr. Rauh-Hain?
Yeah, I think I understand
Okay.
the question. I just want to make sure that if the person who asked the question is here, just like we're talking about small bowel obstruction. Most of the times, most of the small bowel obstructions are because the cancer came back, so are what we call malignant bowel obstruction. So I'm gonna talk about that, but keep in mind that some bowel obstructions might not be cancer related. They might be from adhesions from prior surgeries. But I would say in the majority of the cases, the large majority of the cases, if someone has a bowel obstruction, is because it's caused from the cancer.
Yeah, she just confirmed that it is from the cancer. So yeah.
Okay.
Yeah.
So, how often can we treat it? Like in terms of how often the bowel obstruction is gonna get better?
So the question was that, yeah, when dealing with that and a PEG tube to drain and IV nutrition, how often does the obstruction actually clear? When on Mechanist, I'm assuming that's a drug name, MEKENIST. Alone. Okay, and the patient can resume eating or drinking as normal.
Yeah, I would say that, and everyone's a little different, and bowel obstructions, sometimes there are all ranges of bowel obstructions that we see. There are patients in which they come into the hospital with an obstruction, and I say this because there's again, I'm gonna try to simplify it as much as I can, but keep in mind that there's a wide range of outcomes that can happen depending on where you are in your cancer treatment.
Mm-hmm.
What I mean with that is that, first of all, some bowel obstructions, very few of them can be cured or can be relieved by surgery. I guess that doesn't happen very often, to be honest, but sometimes if it's an isolated recurrence, like just one area that it's causing the recurrence, we can do surgery. Again, that doesn't happen very often. The second part is whether you are going to respond to chemotherapy or not. Either you're platinum sensitive or platinum resistant. If someone has a bowel obstruction and it's a platinum sensitive, then we can put a G tube and an NG tube for a little bit. Hopefully the bowel obstruction resolves, and then we can restart treatment, and then hopefully treatment is going to shrink the cancer and the bowel obstruction is going to go away. So if you have platinum-resistant disease, the chances that the cancer is going to respond are much less. So in those scenarios, the situation is much more complicated. And there's really not many things that we can do for malignant bowel obstructions, because malignant bowel obstructions, it's not a one point of obstruction. It's probably like the cancer is covering the small bowel. And in that scenario, we can alleviate the obstructions for a little bit, either with an NG tube for a little bit if you're in the hospital, with a G tube. But the question is, long-term, what we can do for the cancer. If there are therapy options for that. Because if there are not good therapy options for the cancer, then the obstruction is just probably not going to get better. Again, there are different therapies that you can try. We can try corticosteroids. We can try other therapies that help, like the absorption of different things in the intestines. It's something called octreotide. But all of those therapies have like short-term benefits and really no long-term benefits because the cancer is still there. So I don't think I'm giving you a very straightforward answer, because this is such a wide range of outcomes that can happen. But the most important thing is depends on what is the long-term options for the cancer. If there are options, then perhaps the therapy would help relieve the obstructions. But if the options are not great, then we have patients that unfortunately they don't do very well with the bowel obstructions.
Thank you, Dr. Rauh-Hain. Moving on to the next question. So when the cancer if you find cancer in the psoas muscle and the femoral region, are there any treatments to reduce the spread or eradicate it from the muscle? And what does the progression look like? And does the patient become incapacitated and unable to ambulate, etc.?
This is ovarian cancer that has spread to the psoas muscle?
Yes. Mm-hmm.
Okay. So, I mean, there are a lot of things that, with all of this, with ovarian cancer, it's part of it is where it's located, but also it's where in the therapy journey the patients are, right? I mean, if it's the front line, if it's platinum sensitive, if it's platinum resistant. So most likely the options are going to be different depending on where the patient is in the treatment journey. There are more options, of course, if patients in the front line or in the platinum sensitive, and less option if someone has platinum resistant disease. I would say in terms of treating, and that would be in terms of treating cancer that has spread to the psoas muscle. First of all, that is a very uncommon scenario. I don't think that happens very often. I've probably seen it a couple of times in my career. But if a patient is experiencing significant pain because there's some nerve involvement, one of the options that can be considered would be radiation to that area to see if that can shrink the tumor and help alleviate the tumors and help alleviate the pain. That would be something that I would think about. Again, all of these depends on, performance status of the patient, other treatment options. So that would be one option. Other option is like if there's platinum sensitive, obviously giving chemotherapy, clinical trials, and so forth. I don't know if hopefully that answers the question that we're asking.
I hope so. And if you are here, and please feel free to. Yeah, she said that. Thank you and yes, so it did answer her question. So that's good. So the next question here is, what are the side effects of peritonectomy, both short and long term? And would someone expect to have long-term discomfort from it? And do you have a higher chance if adhesions, and what can you do about them?
So
that was the question. Yeah,
I think it's important to, so the peritoneum is a layer that it's inside of the abdominal cavity, and it's like a layer that covers pretty much everything inside of the abdominal cavity and part of the intestines. And with ovarian cancer, it's very common that the cancer spreads through the peritoneum. and it's very attached to the peritoneum. And the peritoneum is like just a very thin layer, again, that
Mhm.
covers everything inside. It's hard to explain it until you see it. It's much easier to see in pictures. But anyway, so many times, because the cancer spreads to the peritoneum, what we do is we resect that part of the peritoneum, and in some situations, we resect all the peritoneum. But the peritoneum really doesn't have any long-term function. So removing the peritoneum doesn't really lead to any other, issues or complications long-term. So there's really not a problem removing the peritoneum at all. It doesn't cause more pain. It doesn't cause any, again, should not cause any other issues. In terms of adhesions, anytime that you do surgery, there's risk of adhesions. Obviously, the larger the surgery we do, the higher the risk of adhesions. So if you have a minimal invasive surgery, and we have a trial looking at minimal invasive surgery for ovarian cancer, the risk of adhesions should be much lower than if you have an open surgery. So, but there are other things that can lead to adhesions like infections and so forth. There are some, it's not really medications. There's some therapies that we can put inside of the abdominal cavity at the end of surgery that can help prevent adhesions. All of those, it's called Ceprafilm, and there are other names. All of those, really the benefit is not that clear. So some surgeons use it all the time. Others are more restrictive. But I would say that might be the best option to try to prevent adhesions, but they're not that effective. But certainly removing the peritoneum it should not cause long-term effects.
Thank you. Moving on there are a few questions on the chat. I'm going to switch over to that. So there's a question that I've been told there is no numerical milestone as far as post-treatment with no evidence of disease. Is there, however, a prognostic value to the number of years that pass without a recurrence?
Yeah, I think so. It's a very good question. And I would say that for us, like 5 years is a benchmark. And to the point that after 5 years, according to our guidelines, we stop following patients, right? There are few patients, it doesn't happen often, that can have recurrences between 5 and 10 years after the original diagnosis. But I would say if you reach the 5 years, the chances are very good that the cancer won't come back. Obviously, there's no guarantee, but I would say 5 years. Recently, and when I say recently, a year ago, there was a paper published on PARP inhibitors, specifically for olaparib, looking at 7 years, thinking that that was also a good benchmark to say if you're past 7 years, you're almost considered that you're cured. I would say between 5-7 years, I would say that's a good benchmark. There are a few patients that can still have a recurrence after that, but that doesn't happen very often.
So I'm going to ask a follow-up on that question. You said that, after 5 to 7 years, you could consider a patient to be cured. I mean, that's a huge, for anyone to even get that message, that's tremendous, right? And so what percentage of patients actually recur after 5 to 7 years? Is there any data available on that?
I would say, like if you reach to 5 to 7 years, the chance that you're going to have a recurrence, I would say it has to be less than 5%.
So less than 5% of patients beyond the 5 to 7 years recur? Is that what you're saying?
So yeah, exactly. So if you reach to 5 to 7 years, I would say the chance that you're going to have a recurrence, it has to be lower than 5%. I don't know there's an exact number out there. But the number of patients to get to 5 years without having a recurrence, it's less, it's like 90% of the times the cancer will come back within 5 years, right? So it's a small population of patients that get to those 5-7 years. So
no, we'll take that. We'll take that. So
yeah.
if a patient makes it to 5 years without a recurrence, regardless of the stage of diagnosis, if I'm hearing you correctly, then the chances of the cancer not returning is over 90%.
Yes.
That's what you're saying.
Yes.
and friends. I mean, that in itself is a moment to rejoice. I mean, I understand that what you're saying is, majority of the patients do not make it to the 5 years without a recurrence. I understand that. But for those who do, the chances for the cancer coming back is minimal, is what you're saying.
That's correct.
Okay, thank you. So then there are a couple other questions. So if your next question is, if you're stage 3 high-grade serous platinum sensitive with recurrence in 15 months after receiving carbotaxol plus Zejula, what would you recommend for next treatment? She had a successful debulking surgery upfront also.
So she's platinum sensitive. So that's the first thing. So it's important. The second thing that I would want to understand is where the cancer is located. If it's in one isolated area, and we're pretty sure about that, and she might be a candidate for secondary debulking. So that's the first thing that I would try to figure out. So for secondary debulking, usually, and there's different guidelines that we follow, but usually the straightforward is the easier to understand is if it's isolated, so just one area of recurrence, 1 or 2 areas of recurrence, and the patient is platinum sensitive, usually that's a patient that we can do a secondary debulking, usually, as long as the patient is fit for surgery and so forth. Again, unfortunately, that doesn't happen very often because most of the times when the cancer comes back in multiple places, and that's not amenable for surgery. So for someone who's not a candidate for surgery, then the options are chemotherapy, platinum-based chemotherapy, and the options would be carboplatin paclitaxel. If the patient doesn't have a lot of neuropathy, that's an option. I like to use carboplatin paclitaxel again if I can, if the patient doesn't have significant side effects. The other option is carboplatin gemcitabine or carboplatin doxil. And I would say that there is very compelling data about using Avastin or bevacizumab for patients that have a platinum-sensitive recurrence, to the point that there is a trial that we call GOG-213, in which adding Avastin to the chemotherapy improved the survival for those patients. So, so for someone who had a PARP inhibitor before, perhaps my option would be carbotaxel plus bevacizumab. That would be my go-to thing. But again, there's a lot of things that you can consider based on toxicities and so forth. The other part to consider is that if someone is BRCA positive, there's a trial in which patients that receive a PARP inhibitor in the front line or an earlier line receive a PARP inhibitor for platinum-sensitive disease. As long as they respond to platinum-based chemotherapy, they can receive a PARP inhibitor again. And there was an improvement in progression-free survival for the patients that received olaparib. Again, that trial was only for patients that were BRCA positive, and there are a lot of issues with the trial. So I think it's something that we talk to patients that are BRCA positive, but it's not something that we frequently use in that scenario, to be honest, but something to talk about.
Thank you. So the next question is that she's had both breast and ovarian cancer 17 years apart. But she says that I do not have a BRCA mutation, even though she has both breast and ovarian cancer. Any thoughts on the culprit of these diagnoses then?
So there are other things and there are other mutations that can lead to breast and ovarian cancer. So I would make sure that she talks to a genetic counselor and she undergoes like a complete genetic testing panel, not only for BRCA, but for other mutations. And if there's nothing, then, it's hard to know what exactly happened. And it's one of those things that maybe in the future, we're going to identify new genes and so forth. But I think the most important thing for this patient would be to definitely talk to a genetic counselor and see if she had a complete, a full panel to make sure that all the mutations were assessed.
Thank you. The next question is, with recurrence, are there surgical debulking options to limit or prevent other complications such as bowel obstruction before it happens? That's a good question.
So there's for secondary debulking, there are very clear indications that I mentioned them, like isolated, like oligometastatic disease, like just one, perhaps two sites of disease. Patient has to be platinum sensitive and good performance status and good candidate for surgery. In terms of if someone has, and I don't know if this is the question, but something that can happen is a patient that has a cancer and might lead to a bowel obstruction in the future. And I think that is the question that's my understanding of the question. Again, all of these are different grades of things that can happen in different clinical scenarios. But I would say in general, we don't do prophylactic surgeries for potential bowel obstructions. There might be scenarios in which we might consider for a large bowel obstruction that are very different than small bowel obstructions. But again, I would say those are very unique clinical scenarios.
Thank you. And if you're here, you are welcome to ask Dr. Rauh-Hain directly if there are any follow-ups to if you needed any follow-up to the answer he just gave. If not, then we are going to move on to the next question, which is still staying on chat. So the question is taxane as effective?
Nancy, I'm so sorry.
Absolutely, please do.
I made a mistake because as I said, the tax prefix, I meant Taxotere, obviously. Taxotere versus Taxol, because they're both taxanes. Because, so my doctor said, no difference, don't worry, you have MS, why have more neuropathy? And I made perfect sense, and that was fine. Do you also believe, is one preferable to the other in terms of actually treating the ovarian cancer, not preventing neuropathy, or are they equivalent by, basically, in your opinion? Thank you.
Yeah, no, such a good question. So there's definitely more data on Taxol than on Taxotere, but there's actually a very large trial that was done in Europe for Taxotere, and that showed very good outcomes similar to what we've seen with Taxol. So I think it's very reasonable in your case to use Taxotere. I think Taxotere has other side effects that you probably have experienced, like they have to give you growth factors because your blood counts can go down, you can have edema. So it's not like it can be better for the neuropathy, but has definitely other side effects. But I would say there's no head-to-head comparison, but probably it's the same. And we use it we use it frequently in situations like yours.
Thank you. So I'm going to, I think I missed this question. It was like first on the trail. There was a question that, did you really mean to say cure for BRCA women with and PARP inhibitors? Yeah. I think it's hard for us to talk about curing ovarian cancer, I'll be honest. But that data that was published in the Journal of Clinical Oncology of using olaparib based on the SOLO-1 trial, looking at 7 years, is very compelling. Very, very compelling. To the point that we are thinking that we're curing some patients. Thank you. So before I move on to the next question, if anyone wants...
Just give me 1 second. So sorry.
Please. Yeah.
Sorry.
No worries. Thank you. We appreciate that you take the time to come to these forums and give your time so freely. So thank you. I know how busy you doctors are with surgeries, treatments and patients on calls, all of those things. So moving on to the next question is, why is progression-free survival relevant to someone who has responded and been on treatment for 3 years?
Okay. Sorry, can you repeat the question?
So the question is, why is progression-free survival relevant to someone who has responded and been on treatment for 3 years? So that's how the question came in. So
okay. So yeah. I'm gonna try to answer this. I don't fully understand the question very well, but so progression-free survival, what it means is the time in a trial, from the time from the patient when the patient was entered into the study until the patient experienced the first recurrence. So you can be on therapy, on maintenance therapy, and have a recurrence, right? So that means, let's say that you had a recurrence within 16 months of starting on the trial. That means that your progression-free survival is 16 months. So even though you're maintenance therapy, you can still have a recurrence, and that will shrink your progression-free survival. So that's why it's important. And the reason why we use progression-free survival as the primary endpoint in many clinical trials in ovarian cancer, although this is controversial, is because we want to assess really the efficacy of the therapy, and because patients can always cross over and receive the therapies later on. And it's hard to know what happens afterwards. So that's why it's easier to kind of manage what happens from the diagnosis to the first recurrence and not take into account what happens afterwards. So that's why we use many times PFS as a primary endpoint in clinical trials.
Thank you. So there's a question in the chat that I'm hearing that with platinum resistance, there are options that you, as also you mentioned. What are some of the trials to look for when it comes to platinum resistance?
Yes, so platinum-resistant disease, it's definitely a challenge. It's definitely a challenge for us. Hold on. Sorry, I'm at home and my kids are still here and haven't got summer.
That's fine. It's summer. We understand that. We will even have them like with you and say hello.
So platinum-resistant disease. So there are a few options available. I think we're expanding the options available. So probably you have heard about mirvetuximab, the folate receptor antibody conjugate, but there are many other antibody conjugates that are being currently tested in platinum-resistant disease. Some of those antibody conjugates are for folate receptor alpha, but there are actually other targets as well. So there's a huge amount of opportunities right now for platinum-resistant disease in clinical trials. So it's just a matter of finding the right institution where to go to for the trials. But there's a lot of trials available for platinum-resistant disease.
Thank you. So there's another question that it's an interesting one. So she's saying, my sister and I got ovarian cancer about the same age, 60 and 62, had genetic testing at Iowa and MD Anderson and Mayo, all negative except watching one mutation. Have you seen anything like this? We are both BRCA negative, HRD negative.
Yeah, I mean, I've definitely seen family members that both had ovarian cancer, a strong family history, and that have had genetic testing that it's negative. Yeah, it happens. I think it's similar to the question about that we had before, breast and ovarian cancer in the same patient. I think it might be that eventually we identify more mutations. And so one of the things that has happened is that, we, like 10 years ago, we had a panel for genetic mutations for BRCA, and that panel was updated. So if you had genetic testing 10 years ago or 12 years ago, you probably should repeat the genetic testing. But it sounds like if you went through all of those institutions that, you had probably the most new, most recent genetic testing.
Thank you. So I know we are getting short on time. We are about 7 minutes away. So I have a couple more questions. One is, while mucinous ovarian cancer is more rare, there does seem to be a large population that is caught in either the precancerous or the stage 1. Is there a particular center that is focused on this subtype? And essentially, how do we get our sample to the right researchers as survivors? I think it's an important question.
Yeah, so just like we talked about low grade before, mucinous is, now we understand a completely different disease, like the mutations that the cancer has on mucinous is different. Patients with mucinous ovarian cancer usually don't respond if they have advanced stage. as well as the chemotherapy as patients with high-grade serous ovarian cancer. So I think it's very important if you have a mucinous ovarian cancer that has come back to go to a place in which they have clinical trials or at least expertise in mucinous ovarian cancer. I work at MD Anderson. I know we have someone who sees only mucinous ovarian cancers at MD Anderson. I don't know about other places, so I don't want to. I'm biased, so like my recommendation would be to make an appointment to go to MD Anderson, but I don't want to also cause any conflicts of interest.
Makes sense. Thank you. And so the next question is, I feel bloated and pain inside my body. My last chemo was February 28 or 29 of this year. Just like in July when they gave me a diagnosis of stage 4 cancer. I'm taking chemo drugs, which also contributes to my pain. My tummy hurts, and when I lie down, it is difficult to unwind and relax. My stomach is so tight or bloated. I haven't had a CAT scan for quite a few months. Don't know what is going on. Any guidance would be appreciated.
Yeah, I mean, it's hard for me just to tell you exactly what's going on just by this. But I think to me, it sounds that probably doing imaging sounds like a very reasonable next step. So I would definitely reach out to your oncologist and be seen in clinic. And, I'm hoping that they can order some imaging.
Thank you. I think we have time for just one more and then wrap up. So there's a question from Ronnie, and she's saying that she has a final question as a follow-up that is there data you cited also as compelling for BRCA negative HRD positive with regards to that 5 to 7 years with no recurrence? And
so unfortunately, we don't have that data for patients that are HRD positive.
Okay, thank you.
It doesn't mean that it doesn't.
Right, no.
The same. It's just that data has not been published yet.
Right. Thank you very much, Doctor.
Thank you. And so just, unless there are any more questions, I have a couple just to, okay. So the next question is vaginal cuff reoccurrence hard to treat?
So it all depends on what is the treatment history. And if it's the first time that the cancer comes back, and it's platinum sensitive, then there are many options. If someone has to undergo various lines of therapy, then obviously more challenging. If it's an isolated vaginal recurrence, and I think it would be unlikely, but I'm just throwing out there that it was isolated vaginal recurrence. It's something that perhaps we'll think about radiation. We don't use radiation very often in ovarian cancer, but if it's isolated to the vagina, that might be something to consider.
Thank you, Dr. Rauh-Hain. We are about to get to the top of the hour, so I'm just going to. I don't think there are any more questions, so I'm just going to ask you. You already talked about clinical trials. You talked about your study. So just tell us, in terms of the Ignite TX study that you're doing, it's a very important study, and for our overcomers and their family members that want to sign up for this, where do they look and how do they go about that?
So thank you so much. So the patients can self-enroll into the study. So what I can do is I can send a flyer that we have, and also we are in social media, so you can look in social media, or you can send us an email, and I'll send the flyers. If you receive the flyers, it's very easy. There's a QR code, and through the QR code, you can log into the website, and it's very easy to enroll. Very, very, very easy to enroll. So if you have a BRCA, if you're in the call, if you have a BRCA mutation, or you have a friend who has a BRCA mutation, or a family member who has a BRCA mutation, this study really can help you or your family to complete the genetic testing. It doesn't cost anything. It's very easy to enroll, and pretty much what we do is to help you navigate, the diagnosis of BRCA, and then help you find places where you can have the genetic testing. And actually, for some of the participants in the study, depending on which arm you're randomized, family members can receive free genetic testing. So around 50% of the family members that participate in the study will receive free genetic testing, and the other 25% will receive a lot of help from a navigator to find places where they can get testing. So it's really a resource for patients that have ERCA, so they can really help their family members. And again, this is the only way right now that we have to prevent ovarian cancer. So this is why it's so important. So I'm gonna put in the chat the access to the website, and then hopefully we can help distribute the flyers through all, through Ovarcom.
Thank you so very much. Yes, that would be very helpful. If you can send it to me, then I'll make sure that, it goes out to everyone that's on the call today. And also, obviously, you and I have talked about, doing more on this. So, so do you offer any virtual appointments? That was
So it's an interesting question. I can see patients virtually. Yes, it depends on the state, because we don't have license for all the states. I would say that if someone wants an appointment, you can call MD Anderson and request an appointment. You can request for whoever you want to see there, and they'll help out. Or if you want, I'm happy to share my email if you wanna. I'm gonna put my email in the chat if you want to ask me directly what is the specific question.
Thank you so very much, Dr. Rauh-Hain. This was amazing, and I know that all our Overcomer friends on the line, I'm pretty sure that you also enjoyed this conversation. I know that you all stay so busy with your patients and the great work that you do, but just taking time to be here with us and answering all the questions, we are truly grateful to you for your time. And Overcomers will be back with the next OC 360 Live very soon, probably in the next couple of months. But meanwhile, you enjoy your summer. And again, Dr. Rauh-Hain, thank you very much for your time today. And I'll be in touch with you separately to do more with you. Yeah.
This was great.
Right.
Thank you so much for the opportunity.
Thank you so very much, everyone. Thank you. Take care. See you. Bye.
Thank you. Thank you so much. Happy summer.
Happy summer to all. Bye.